the way, and then we'll wrap things up with Hannah at the beginning. So we've got Sam Hazeldine presenting for us again this year. He came last year, and I didn't realise he was an absolute Queenstown legend. We were at the sauna workspace about 10 minutes out of town, which is pretty sort of rustic sauna experience. And Chaz, the guy that was leading us through, was asking us what we're doing in Queenstown. And at a conference, and oh yeah, what sort of conference am I leading? Oh yeah, Sam's speaking. And he's like, oh wow, you've got Sam. So yeah, really excited to have Sam. And let's have a big round of applause for Sam.
That's got to be the most embarrassing introduction I've ever speaking. I'm not a Queenstown legend. Also happy to hear that you do have access to the bar. The greatest fear of a public speaker is being on the end of a conference, last thing on Friday, being the last thing to you in the drink. So glad to hear that is not the case. I'm thrilled to be here. I'm always really honoured and excited when I get to speak with people in healthcare. And that is what I'd quite like today to be, is a conversation. I'm not certainly most of talking, but to some extent a conversation. Because I think we'd all agree that healthcare has room to improve. I think we're struggling in many ways. I think we're struggling as individuals. We are struggling, as a collective. But healthcare is struggling. Delivery, everything is just creaking at the seams. And I really think that we need to do better. I think we can do better. So what I want to do today is just introduce some ideas, tell you some of the things that I'm doing, that we're trying to do to advance things and make things better. And I think that's what it's going to take. It's just going to take a lot of people pushing on a lot of fronts, quietly improving things. And so let's make this part of the conversation. How do I do this? I've got a technology company, but I struggle with these things. I know. All right. So yeah, my name is Sam Hazeldine. I'm a doctor, and what I want to talk today is about what does a better future look like in healthcare. So a little bit about me. I graduated back in 2003. Dr. Gerard here. His father was the dean of the medical school. His mother was then the RMO coordinator who looked after me as a first year house officer. I took some time out after I graduated, competed as a professional skier, became national free skier and extreme ski champ. And then I started working as a doctor. And, whilst being very much supported by Barbie, I could see that a lot of us were struggling. A lot of me in particular, but there were a lot of people struggling. People were just getting burnt out. They were becoming disillusioned. They were leaving the profession in rapidly increasing numbers. And at the time, I hypothesised, as a young doctor, I was like, you see things from your own part of the world, and I was like, medicine hasn't evolved to cater to a younger generation of doctors. You've got an old guard saying this is how it was, this is how it will be for you, and there's a young guy going, right, we'll just check out and leave. And I think that was driving a lot of challenges. So my hypothesis was that if you can help doctors create a lifestyle in medicine, then great, they'll probably re-engage, find what it is they love about the profession, and get back into it. And so I founded MedRecruit back in 2006, and inadvertently pioneered a sort of a doctor-centric approach to staffing. I wasn't a recruiter, I was a doctor. I always saw my company as a healthcare company, not a recruitment company, and it was about helping doctors. It was about helping doctors create better lives, enjoy themselves, get out of the rat race, re-engage, and be the best doctors they could. My hypothesis was, look, happy doctors practice better medicine. It seemed pretty logical. We grew pretty quickly. We were in 2009, we were the fastest growing service business in the country. We're now the largest medical staffing company in Australasia. But along the way, I was also got more interested in some of the challenges I was very privileged to be able to work with hundreds, thousands of doctors, helping them in, understanding their challenges. When at the start it was me talking to every single one and understanding what their stresses were, what the challenges were. And so that led me naturally into some research. And it was about 15 years ago now, it's a long time ago, that I was doing some research into burnout. And I found that 1 or 2 doctors were in burnout. Now this shocked me. I mean, I knew things were bad, but 1 and 2, that really struck me as an issue. But what got worse is when you see that, and we know this now, we all know this, burnout leads to depersonalisation, emotional disconnection from our patients. We all know this, but it surprised me when I discovered that, and then that depersonalisation leads to increases in major medical errors. The way we were living and behaving and practicing health was causing us to harm our patients. And once you start to put some research and some stats around that, it becomes relatively intolerable. So that's when I set up MedWorld. And initially I set up MedWorld as a platform to lobby for change, as an advocate for doctors, as an advocate for healthcare. As a recruitment company, you're sort of seen as one of the bottom feeders. As recruitment companies, used car salesmen, you're down there. So I figured I needed a different entity to lobby for change. And so that was MedWorld. And I used MedWorld to lobby the World Medical Association to amend the Declaration of Geneva and the 1-day Hippocratic Oath to include the health and well-being of doctors. Talk a little bit more about that later. But it was about advocacy, it was about research, it was about trying to find solutions. What we've done now is to split that out into MedWorld, which is building technology to help in the staffing space. I'll talk a bit more about that. But also the MedWorld Institute, which is a charity focused on research. But through all this, I remember it was back in, it was about 2013. I had a daughter who then was 1 and a daughter who was 3. And we were up the gondola here with the kids doing some lugeing. And Claire, my ex-wife, pulled out a camera and took a photo of me. And that was the photo. And I was like, why are you taking a photo of me? And she's like, because you look like shit. She's my ex-wife. But no, she's like, you look like shit. She's like, Sam, I just took a photo so that you could remember this moment, because you put so much into your kids, you put so much into your work, your mission, what you're doing, and you're doing nothing for yourself. Now, I've been researching burnout. I've been, championing doctors, and throughout all of it, I was getting a bit more tired. I was enjoying my work less. I sound familiar? I was just sort of starting to care a bit less. And so whilst I was, considered an expert in the field, this, was insidiously, it was creeping up on me. So I decided to do the burnout test, and I was at the high end. That's how, that was a moment for me when I realised this is so insidious, this is so hidden. We don't realise how much we're struggling when you can be immersed in a space and still not realise that the thing that you're researching has caught up on you. And so that was a catalyst for change for me personally, but also a catalyst for, okay, what are we going to do differently? As I said, what I'm sharing with you, this is nothing new now. I used to call it medicine's dirty little secret. It was something that we thought, we knew was there, we knew some people were struggling, we didn't know to what extent, but we just kind of pushed it under the rug. But it was something that we just tolerated. And it got to a point, I think, where now, thankfully, it's not something we're tolerating anymore, but we don't necessarily know what to do about it. Because who knows, what's the core principle in healthcare? First, do no harm. I mean, that's the core thing, that, we're not here to harm our patients. None of us would not knowingly, give a patient a medicine that had only side effects and no benefits. It would just be stupid. But as a healthcare, as a sort of the organism of healthcare, we are doing that in the way we're treating our people. We're doing that in the way that we are looking after the people in healthcare. We're doing that in the way that we're delivering, because we are letting things get to a point where we're struggling so much. And as I said, we all know the cost. This is the low struggling, paramedics are struggling, we have increased rates of mental illness, suicide, substance abuse, we have higher divorce rates, we have higher marriage dissatisfaction rates. Like, it's not working. So what are we going to do about it? You know, I think part of it is because of we've operated for a long time under this paradigm of I'm going to sacrifice everything because my patients come first. You know, who felt that was, without being overt about it, who sort of felt like they came out of medicine going, you know, whatever the cost, you know, it's all about the patient. And so there's a problem with that, though. There's a problem with that, and the research, you know, supports that. That isn't working. You know, sacrificing, you know, the individual for the patient is causing long-term harm on the patient. But it's a very difficult call to make, isn't it? Because we've got urgent and important. You know, it is important to look after ourselves. It's important to look after our mental well-being and our health and our physical well-being. But the urgent thing is, you get a call from Barbie at, you know, 4 o'clock on a Friday saying we haven't got an Aotearoa to do nights this weekend. What are you going to do? We have this challenge within healthcare that the urgent is also very important. I think it's time for us, and if we sort of adopt a different paradigm, then that's how collectively we move healthcare forward. That's collectively how we make some change. We take care of ourselves and each other because our patients deserve us at our best. Now, I used to say that, you know, and I've been evolving what I think this needs to be. But I used to say I take care of my well-being because my patients deserve me at my best. But it's not just a me thing. You know, it is a we thing. And I think that's the really important thing. It's every single one of us moving in a direction is what's going to make you know, major change within healthcare. It's never going to be one person. It's never going to be the government. It's never going to be the DHB or whatever they're calling themselves at any point in time. You know, it's never going to be one of the health districts. It's going to be us. It's going to be the people on the front line. That's how we're going to make change. We all need to play our role because I think, you know, we have normalised bad behaviour. We have normalised this sacrifice everything for the patient. So we need to, bless you, we need to normalise a new behaviour. You know, it's a shared problem, therefore it has a shared solution. And I'm going to get into the conversational part, but you know, initially my hypothesis was this is about the values. This is because we didn't value the health and well-being of the healthcare professional. And that's where I, you know, went on my crusade to go, right, if we can lobby the World Medical Association and amend the Declaration of Geneva, the modern day Hippocratic Oath, the value set of doctors. I remember when I was speaking, you know, to do research into well-being and burnout, and I was invited to speak to all the graduated medical students around the country. And I would get up and talk about my research, and I'd talk about what I found helps and how they could potentially help themselves in their first year as a doctor. And then the next person who was on tour with me was Dr. Stephen Child. He was the president of the New Zealand Medical Association at the time. And he got up, actually funnily enough, the first time he got up, he's listening to me, then he gets up and goes, you know, I used to think Sam was everything that was wrong about medicine. I was like, well, great way to start a week on tour, buddy. I was like, there's everything wrong about it. You know, he's all about the, you know, I saw this, you know, his marketing, his advertising was about the doctor and having a lifestyle, and he's like, I can actually see now we're all coming from the same direction. You know, so I was happy firstly that Stephen Child had come over to my camp. But secondly, he then got up and started talking about, you know, what it means to be a doctor, who we are. Here's the Declaration of Geneva, 10 points. This is the value set of doctors worldwide, and this is something to be proud of. And I remember reciting it when I graduated. I felt proud to be coming into this great profession. And I'm sitting there, and I'm just speaking about well-being, and looking at this, feeling great, and then I'm like, hang on, there's nothing in there about the individual, the doctor, the well-being. So I was like, if we could change that, we could change everything. You know, naive, let's go, this will change the world. And so I drafted something up, we got over 5,000 doctors to sign a petition, presented it to the World Medical Association, they considered it, blah, blah, blah. The following year, they unanimously voted to include, I will attend, my language was a bit more, I felt punchy, but they have their own elements to it. I will attend to my own health, well-being and abilities in order to provide care of the highest standard. And I thought, this is it. You know, this is the values, we're going to change, everything's going to change. Remember when I said like 15 years ago, one and two doctors were in burnout? 2 and 3 are now in burnout. things haven't got better, things have got worse. What it has done, I think, is put it on the helped to put it on the agenda. There's no one who's, there's no healthcare organisation that's not focusing on it, is there? Every department is focusing on well-being. They should be. Every hospital is, every health district. We're all thinking about it, but we don't necessarily know what it is that we need to do. So what is it going to take? This is the part of the conversation where I think, that I'd love to get more interactive. Like, what is it going to take? I'm going to give you my ideas, but what is it going to take to actually move healthcare forward, to make it better, to not have our individuals struggling en masse within it. You can't look at the individual and go, it's an individual problem. This is a collective. If you have, remember there was that issue in New York, in the 1960s or whatever it was, and the garbage men went on strike. And so the rubbish was piling up in the streets, and there were rats. Rats became a huge problem. Now the issue then wasn't the rats burning. The issue was the rubbish. So the question I have is, how are we going to remove the rubbish? How do we make healthcare better? And I'd love to get your ideas about what needs to change. Anyone got ideas? What do you think needs to change? Staffing levels, 100%. I mean, that's exactly right. I mean, anything when I talk about well-being, the foundation is staffing. If you get staffing right, I reckon you're 80% of the way there. Absolutely. What else? Consistent roster. What, to support the individuals within that roster? Right? Yeah. Yeah, right. So thinking about, I guess, individuals within the system actually working to them rather than just flexing individuals to the system. Yeah. What else?
Realistic expectations of both the individual, the staff they work with, and the patient safety.
Okay. Tell me more.
Well, many years ago, you'll see a customer come in at 10 o'clock on a Friday night with a 3-year problem. They're seeing quite specialists and have many scans, and they want to fix it.
Mm-hmm.
And you're like, dude, it's good.
Yeah. Yeah.
And even though it's a ridiculous scenario, that does happen
Yeah.
quite frequently. And unless you are profoundly autistic, you have to take a little bit of that on yourself and say, should I be able to do this?
Absolutely.
Should I be able to treat?
Yeah.
You're basically full of patients.
Yeah.
There's only one pair of hands in the end of your arms.
Yeah.
They're all out there, they're all sick, and you want to heal them all. So you push harder, you take less breaks, you have
Yeah.
quicker, you start making mistakes,
Yeah.
you cause improve. So, in fact, patients have an expectation they can rock up to a
and they're more principles, right? And I'm very keen to hear thoughts, because this is not, these aren't my ideas. This is what I'm talking to a lot of doctors. But to me, I think it's important. Well-being is a problem, but well-being is a symptom. Burnout is a symptom of, it's at the bottom of the cliff. How do we move up the cliff? And to me, what I like to think about is, I like to think about the health of medicine. So when I think about the health of medicine, it's, the individuals in medicine are thriving, the system is thriving, and the patients are thriving. It's actually, relatively simple. It's about focusing on the organism rather than focusing on the symptoms. And to me, I think it's interesting. There's a couple of times we've heard about the grey-haired professor. Some of us, go grey a little earlier, but it's the Gerard gene, isn't it? But he was the good professor. This generation is I think ready for change. And I was at my medical school graduation just over a year ago, and there was a lot of us turned up. It was about 43, I think, and so everyone had a chance to get up and just sort of talk for a few minutes about what they're doing. What I loved about it, what struck me about it, was every single person talked about some of the challenges they're facing, and every single one was like, willing to make change, to be different. The 70-year-old grey-haired professor, whilst they exist, I think we've also got to think about them as a bit of a myth now. Like, there is a different generation of leadership. It's my age group. It's, I'm 45. It's 40-year-olds, 50-year-olds, 30-year-olds. It's, people a lot younger than me. But there is a different generation of leadership in healthcare. And so, continuing to point to those 70-year-old grey-haired professors, it's doing us a disservice. It's kind of disempowering. But when I talk to doctors, and forgive me for, at the moment my research is all in doctors. It's not in nursing, it's not in paramedics. But I've done some reading in those spaces, and I think we're all facing pretty similar challenges. We're facing similar levels of burnout. Like, we're actually all in this together. I look at there are three things that we could do a lot differently, and that potentially could move the needle. Now, one is well-being. Even though it's a symptom, we have to prioritise it. We have to, but I think the thing that is really important, and it struck me, the head of ED in Dunedin was talking about this, and he was talking about the importance of when the junior doctors come to him and ask for leave, for things to do with their well-being. And he said, you've got a moment there where you can either kind of, really? Or you can enthusiastically encourage them to do it. So I think it's in prioritising our own well-being, but for those of us who are in leadership, it's about enthusiastically encouraging the positive well-being steps with our junior colleagues. So I think that's a thing that we can shift quite quickly. And I know it's tough because we're short-staffed, and so someone wants to go on leave for a month to do something. We can look at the short term and go, that's a real pain in the ass, and our faces will tell them that. Or we can look at it and go, well, if I don't do it, so there's a good chance they're going to come to me and go locoming anyway. Let's encourage them, let's encourage that retention, let's look after them, and actually foster a culture of well-being. So I think that's the part that we all get to play. We've got to prioritise ourselves, we've got to actually, as well with our actions and words, make sure that we prioritise, our junior colleagues in particular. I think diversity is something that is heavily lacking in healthcare when it comes to how we move forward. Now, I'm not talking about gender and race. From my research, when I talk to people, it's amazing how many first-year doctors have great ideas. It's not just the consultants. So I think when we talk about diversity, we've got within healthcare, we've got to listen to those younger voices. We can't just tell them how it was for us. We've actually got to hear what they're saying and hear, if you're judging someone, you can't influence them. So we've got to actually hear those younger voices. And I think the other part in healthcare is listening to all the different voices, all the different professions. I think that's why a cultural conference like this is so great, because you've got paramedics, you've got nurses, you've got doctors. You know, we all come at it from a different perspective, but it's all a relevant perspective. And I think that diversity of thought is something that's going to be critical in terms of how we move healthcare forward. And I think the other area as well is technology. You know, technology is something that and I'll talk a little bit more about why we are so slow, I think, with technology. But technology is something that can really help us. I think when it comes to, you know, obviously there's ways we can improve efficiencies, ways we can improve delivery. I think the other way technology can help us is how we can tap into the collective intelligence of healthcare. That's what we're working on at Macleod, is how do you create a networked view of an individual within healthcare, and then you know, looking at their skills and their experience, and then use that network view within a network of doctors to give doctors data-driven career advice. Where are you? Where should you be? What are your intentions? And therefore, what are the things you could be focusing on? You know, that's something that we're doing, which I think can help in terms of individual careers. But then, you know, in the future, the grandiose vision is that as you start to get a view of a whole collective of doctors, and we will move it also, once we've got it sorted, we'll practice on the doctors and then take it elsewhere into the nursing and allied paramedics. But once you have that individual view and a collective view, then you can start to guide people in their career decisions in terms of where they want to be. You know, making sure that, you know, to your point around staffing is critical. How do you help guide a collective to have the right people in the right place at the right time? And I think, you know, there's a mindset shift that is really important to be applied in healthcare, which is what I'll talk about specifically. We have to know when to be flexible. In healthcare, we have and we should in many areas have an incredibly high threshold for the advice we give, for the medicines we prescribe, for the procedures we undertake. You know, double-blind, randomised, controlled trials, they all have their place. I think what that does is it means we require, and as we should, a high level of certainty. And I think that's part of what stands healthcare out from a lot of the quacks, which is, you know, we actually do require proof. But we also have to know where to be flexible. We have to know where we need to apply that rigor, but we also need to know where can we apply more flexibility. Where is it okay to be wrong? Where is it okay to push? Where is it okay to make change and learn? You know, something that's really struck me when I went from running a service business, which is MedCrew, to a technology business, which is MedWorld, building product is about having a hypothesis, testing it in the cheapest way possible. Either, you know, you either succeed or fail, and you learn from that and you move forward. And when I started learning about building product, I'm like, well, this is what we need to know where to apply that type of thinking in healthcare. Where do we have a hypothesis that we can make something better? We try it out. It works or it doesn't. We adapt and we move forward. And I think that's something where we need to know where is the level of rigor and where is the level of flexibility. I think that would really help us in healthcare. You know, I think there is hope, and I think things radically, you know, will change and can change. There is no one, and I'm sure no one in this room is thinking, you know, this is not important. Healthcare is sweet. We've got this on lockdown. You know, we all know it needs to be better, and I think the cool thing about it is we're all actually willing to play our part. You know, the strongly held and self-limiting beliefs can change. And so we can shift our thinking. I think that's a core part of how we actually shift healthcare. Prior to 1954, you'll all know the story, it was considered impossible to run a 4-minute mile. Doctors, in our ultimate wisdom, proclaimed the human heart would explode. And, you know, doctors can be wrong. Because on May 6, 1954, Dr. Roger Bannister, after completing ward rounds in the morning, ran a 3-minute 59 mile. The interesting thing is just 46 days later, John Landy ran a 4-minute mile. The following year, 16 people ran a 4-minute mile. School kids, high school kids are running 4-minute miles now. Once we see what's possible, once we see better and believe that it's possible for us, things can change. you're all, it's special people doing meaningful work. I don't believe there can be a higher calling than healthcare. What you put in to get where you are, and what you put in on a daily basis, and what you deal with it on a daily basis, is incredible, and we don't begrudge that work. As a doctor who doesn't practice anymore, I am in a unique position when I go back into hospitals and clinics to see, you see healthcare from an outsider's view. And I'm in awe of, what the nurses are doing, and what an anaesthetist who can put a patient unconsciousness, or a surgeon who can have them open, or an emergency department team who can resuscitate a car crash victim. That's fucking incredible. And I think that's when you're in the frame, you don't necessarily see that. When I was working as an emergency doctor, you didn't see it, it's business as usual, it's day to day. But you are doing incredible work. And I also believe that we are, as a profession, right where we need to be. The fact is, everything has led us to where we are right now, as individuals and as a profession, and where we go from here is our choice. We all get to play a part, and I think that's the key message I have, is that it's going to take every single one of us, starting to move in a different direction to change the trajectory that we're on. Our choices will create the profession that we leave to the next generation. To me, that's pretty exciting. So I think this generation is we are different. We aren't the 70-year-old professor who's harping on about the old days. We actually, as I shared with the med school reunion, we know that we need to change, and we're actually willing to do it. So I asked us, how would you prioritise well-being for yourself, for your junior colleagues? How do you sort of create that shift where you encourage it in a department rather than discourage it because you know that the work comes back on you? How are we going to embrace diversity? How are we going to listen to different ideas? How are we going to take those ideas and apply them for us to improve? And how are we going to welcome technology? Where are the areas that we can actually make change, that we can improve, that we can leverage technology to do the things that we can't do or that we don't want to do, so we can do what we do best, which is care for our patients and apply the human factor to healthcare. Because I think that's it. That's the exciting thing. Our better future starts with every single one of us, but it starts with all of us as well. So I'll finish up a bit sooner so that we could have a conversation if you want to, but I know I'm standing on the way of the bar. So does anyone have any thoughts or questions before we wrap up? No? Awesome. Well, thank you very much for your time. Appreciate you all. I think you're awesome. I think you're doing amazing work, and I think it's great that you take the time to come and visit Queenstown to, be part of a collective to make things better. So, thank you very much. Appreciate it.
So thank you very much, Sam, and let's take a 10-minute break, and then we'll kick things up again for our final presentation of the conference. Cheers.
Great question. It's different for everyone, isn't it? Yes, I think so. And speaking from personal experience, there's two aspects of it. One is physical and one is mental. And I think you can, for me, I focus on the physical, and you get to a point where there's condition returns. So then you've got to address that mind-body connection when it comes to fatigue and passion and things. So you need to like, it's not as simple as just taking the week off and come back in. You've got to address deep stuff. And I guess the trauma of it, because the reason we get burned out is there's some level of trauma, emotional, physical, whatever. Yeah. Right. Yeah, right. No, you've got time, you just pick up on the other one. Yeah. Yeah. I mean, to be honest, the one lever like if you just bolster numbers by 20%, we'd probably be okay. Like, you know, we can deal, because I think the things like that, we can deal with them when we're in a good state. Like, it's like, that's what we signed up for. But that's the thing, once you're burned out, once you're physically and emotionally drained, then the littlest things, like if you've got a scab or a pick it hurts. Whereas if you've got good healthy skin, you can scratch away and it's totally fine. So I think that's the thing, is we get complete individuals, just the littlest things become right. Yeah. Yeah. Sure. Yeah. Interesting. It probably would make more difference than going to learn about whatever. Yeah. Yeah. Yeah, of course. No, of course. A meditation, a week meditation retreat would probably be far better than traveling to Dallas to go and hear the latest another trauma conference where you can just read the papers yourself. Yeah.
Well, that's good.
Yeah. Oh, I'm sure they would. Absolutely. Yeah.
Still going up and
Okay.
up.
Hey, thank you. Sam.
Yeah.
Yeah, right.
Get through the day, right?
Yeah. Sure.
Lights been tuned down.
It's my 9 months all the time.
What I can do is
And so physicians
let's talk about the European
they'll have scope. The key is the problem is when they go, the answer. Twofold the problem is one, they just have to look the way out of the scope. The second is that the answer is the problem. So they throw, I look at Pally as position. I look at them more as they're just kind of hurling. They're not actually fixing that kind of basket. That's the problem. We're one of the clubs here running on, that's part of the solution in healthcare. And I'm like, what position is that? And the problem, I think the analogy I want to midwives have a big right now to play. The problem midwives are the ones who don't look good and women, you know, and too many, and they say ownership, so all this bullshit, they start to put their own subjective beliefs. So you've got, that's the same with everyone. If you start to put your own subjective beliefs, you can't replace one. And you're supposed to have such a scope and go
what have you done? Oh, we just travel around. That's why you know. That's why I said it. 10 minutes. That's why I said the problem they have. So everyone's we've got trounced and rebel fought about doing some dad burnt out it will be sort of like 2 tonight, so we have 2 minutes. Just a reminder that we would like an extra subject callers, dog white mats, stickers. We have more people on the table. Please grab any at all for them. We really don't have much to in our bags for wait tomorrow, so we'd like to go to a good home. You know the rules, loudest cheer gets the prize, so let's kick things off. Oh, that's a nice one. Bloody clap, that's nice, Rachel. Jumping with joy. Like face reserve. Oh, pretty well. We don't have any aftershocks. The rock star pose, there's not the man there. Got some horse riding. And final one. So I reckon we've got the cow, we've got the kid on skis, and we have 3 prizes, Dylan? Yeah, sure, we've got 3 prizes tonight. And let's go with that one as well. So, round up all the winners. Thank you everyone as well for getting your photos up there during the week. It's been great fun seeing them all. Sorry we couldn't show all the photos that came through. But certainly, we really do appreciate you guys closing up and sharing for us. So, to bring us home, we've got Macleod, who's flown down today to come and talk to us all about CPGs in New Zealand. So let's give a nice big applause for Hannah.
Good evening, everyone. Firstly, thank you very much for still being here. I was worried when I looked at the sheet to be the last speaker on the last day of the conference. There's always a risk run there. I did a dry run earlier today, and I'm not going to film the entire hour, so hopefully you see that as a win. Just by way of introduction, my name's Macleod. I'm an intensive care paramedic and senior clinical manager in Aotearoa, St John. I've been in the service since 2011, and I'm based predominantly in Christchurch, which, for those of you who aren't New Zealand based, that's our second largest city in New Zealand, but still not that big, really. In terms of my role as a clinical manager, I'm responsible for a number of things. So development, delivery and moderation of all our internal ambulance education for all our staff, development of clinical technology enablers, particularly relating to CPGs and education, clinical oversight of all the equipment and consumables and medicines utilised by our ambulance personnel frontline, and probably most importantly, leading the development of our clinical practice guidelines in New Zealand. So a very cool job, I think. Just by way of context, so Aotearoa St John provides road-based emergency ambulance services to about 90% of the country. So looking at that map there, we look after the light green, and the dark green down the bottom of the North Island is looked after by Wellington Free Ambulance, so they look after Wellington and parts of the Wairarapa. In our service, we've got approximately 2,500 paid ambulance officers and approximately close to 3,000 ambulance volunteers who contribute to frontline operational production. We are 81% funded by the Crown for our operating costs, and we make up the rest through people putting donations into buckets outside supermarkets and part charges for ambulances. So, what are the CPGs? I thought it would be useful just to explain that. It's not necessarily a term that's well known across all of medicine. So, in New Zealand, ambulance personnel cannot independently supply, administer, or prescribe prescription medicines. So, we rely on being issued an authority to practice by a medical doctor who grants us an authority to practice at a particular level. In New Zealand as well, in the clinical practice guidelines which formulate our standing orders under the standing orders regulations, we do restrict the use of some clinical equipment and the performance of some interventions as well to specific clinical practice levels. So for example, in St John we say you can't use a mechanical ventilator unless you are operating and have been issued an authority to practice at critical care paramedic level. Likewise, synchronised cardioversion is limited to those at paramedic clinical practice level or above. So as I said before, ATP is granted at a specific level by for us it's our Deputy Clinical Director, Tony Smith. And as well as describing for each clinical practice level what medicines and interventions are authorised by that person to perform independently, we also describe under what circumstances they can do it as well. So just by way of, I guess, awareness, because I know we've got some internationals in the crowd today, just take you through the 5 clinical practice levels we have in Aotearoa St John. So first is our first responder practice level. They're predominantly our volunteers. Their qualification level is a level 3 certificate, which is approximately 300 hours of learning. And the focus for them is on providing immediately life-saving interventions before the ambulance crew with personnel with an authority to practice arrive to provide more definitive and autonomous care. Next we have our emergency medical technicians. Those sit at our New Zealand Diploma Level 5 qualification, approximately 1,200 hours of learning. And they're our first clinical practice level to hold paid roles within Aotearoa St John, although we do have a number of volunteers at this level as well. And then we have paramedics. So paramedics are the first of our clinical practice levels who also are required to be registered in New Zealand. That's fairly new for us and pretty exciting. They also require a Bachelor of Health Science and Paramedicine before they can go through the motions of being granted an authority to practice at paramedic level in our organisation. Then from paramedic we split into 2 specialist paramedic practice levels. One is our extended care paramedics. It's a fairly new authority to practice for us. This group require a postgraduate diploma focusing on extended care paramedicine What's that? That's basically focus on low acuity, high complexity patients, and really the goal of our extended care paramedics is to find alternative pathways, provide urgent care, and do what they can to avoid an ED transport or presentation. And lastly, we've got our critical care paramedics. These have been around a while in various formats, but their focus, they require a postgraduate diploma as well in critical care paramedicine, and their focus is on our high acuity, very, very sick status, 1 or 2, sometimes 0 patients. So the clinical practice guidelines for us are a really, really important document, and we have been on quite the journey. And I thought it would be useful just by way of sort of giving you an idea of the change we've experienced in actually quite a rapid period of time. In the last sort of 15-year period, 2007 to 2022, we've gone from 109 pages to 190 pages to 298 to 432 to 560. Now, why is that? There's a whole bunch of reasons for that. Our clinical practice levels have changed. I mentioned we introduced a brand new authority of practice at the specialist level for ECPs. That required quite a bit of work to sort of accommodate them and what we wanted them to do. Qualification requirements have changed. Previously our paramedics didn't need a Bachelor of Health Science. We could put them through vocational education to spit them out the other side. That's changed. Registration of the paramedic profession also has opened up our ability to push them a little bit more and get them to do a bit more stuff. We have just increased the number of things that our AMBOs can do at most of our clinical practice levels, particularly those with an authority to practice at EUT or above. The people contributing to the development of our CPGs has also increased. Previously it was just the road-based ambulance services, and we have expanded to involve the air sector as well now, which is really cool. And then we had previously done one massive review of the whole document every 2 to 3 years. Now, I'll talk to that a bit later, but we've moved to more of a rolling update cycle. We've gone from having a small enough document that it can just be a wee printed pocketbook that you put in your ambulance pants. It then got pretty big for a pocketbook, so we expanded to a comprehensive version that was still printed. Then we ended up with both pocket and comprehensive. And then in the latter part of 2021-22, we actually amplified the CPGs as well. So where are we right now? We are essentially 3 categories of our clinical practice guidelines. First is our first responder field guide. That's a separate standalone document that's just focused on our first responders. It's pretty small, it's pretty compact, and currently it's still printed, but we do have it in the electronic version as well. The core set of CPGs that everyone at ENT and above utilise are our EAS CPGs. At the moment they're electronic only, and that's going to be the case moving forward. These CPGs are not separate, they're available publicly on a website, you can download the app. We're pretty proud of the app, I'll talk about that a bit more later. If you were to export the content of the EAS CPGs to a PDF, which you can do, it equates to about 668 pages, so it's a fairly hefty document. Then we have our ECP CPGs. So it became clear to us that ECPs are really focused on that urgent care, sort of low acuity stuff, and it warranted almost an addendum to our EAS CPGs. So they are also available on the app, but they are quite separate from our EAS CPGs, and once again, exported to a PDF, they're 605 pages, so fairly meaty. In terms of the people who contribute to the development of our clinical practice guidelines, it really depends on who is affected by the implementation of these guidelines. So we always ensure, firstly, that we've got docs and paramedics on all the working groups. It's really important that even though we recognise we've come from medicine and we still require doctors for our standing orders, we have to absolutely have paramedics involved in the development of these. For EAS, what we're really proud of and what we think is fantastic is we've got ourselves to a place where the development of these CPGs are done in collaboration with Aotearoa St John, Wellington Free Ambulance, and our 3 sort of core air ambulance providers. And what a fantastic thing for us to have a core set of CPGs that anyone in the country is using at any one time. Then for our ECP CPGs, the only two employers of ECPs are sort of the emergency ambulance sector are the road-based ones, so us and Wellington Free. And then I mentioned before we used to do just this massive update, which was a lot of work for everyone concerned, and it came in pretty thick and fast for our people having to digest a huge amount of changes for an already pretty big document. So we made the decision to move to a rolling update where we effectively endeavour to review the entire thing over a period of about 3 years, but we chunk up the update so it's like a third one year, a third the following year, so on and so forth. Why the rolling updates? Well, as I said, it was a big amount of information to dump on people. The rollout, the implementation, the education was also massive too. So the rolling updates gave us some enhanced agility, and it meant that we could accommodate more changes more frequently, which was really good. So some examples of that are, and these are things that you will all be familiar with, supply chain disruptions. So we're pretty limited in what we carry in our ambulances. It's often written into our clinical practice guidelines, and it became evident that the supply chain disruptions were coming around more frequently than every 3 years. We know that the changing landscape of things like pandemics, we learned a lot in COVID that the clinical care that was recommended and the PPE that was recommended changed, like we were changing our own pants sometimes. And we wanted to be able to update our CPGs as soon as we could to align with what the recommendations were at any given time. When you've got a document that's 600 pages long, there's going to be errors. Sometimes they're not a big deal, sometimes they are kind of a big deal, especially for your drug doses, or recommendations to take patients to a particular hospital. When we had a printed version, we had to issue stickers for the gnarly errors that had obviously big issues. You know, there was kind of a bit of finger crossing to make sure that everyone got the stickers that they could put over the right page with the correct information. With the rolling updates, we can fix those errors quickly, and certainly electronic, we could do it tomorrow if there was something particularly hideous. Changes to destination policies, hospital capabilities change every now and then. We wanted to be able to make those changes in our CPGs instead of waiting, you know, potentially up to 2 to 3 years to make that change. Coroner and HDC recommendations, you know, those are the sorts of things that we want to implement as quickly as we can to our CPGs instead of waiting 3 years. And then finally, new and compelling research. So, you know, if something comes around that's really compelling, we want to be able to adopt early as appropriate into our clinical practice guidelines. So, how's the sausage made? As I said before, we divide the CPGs into thirds to make sure everything's sort of at least looked at. We don't have to change it just because, but looked at over every 3 years. And at the start of each review period, the CPG working group will come together and we'll talk about the sections that are due for review and any sections that we want to update sort of out of cycle as well. And big changes are tabled at that point in time for discussion. So is there a significant redevelopment of the CPG that we want to do? Is there a new CPG we want to develop from scratch, and what does that look like? And is there anything in what we want to do or what we want to implement that's going to meet our threshold for internal organisational discussion or sign-off? So something with significant cost, something with significant education implications or other operational implications that just need to be okayed by the big cheeses at our organisation before we go rogue and print something. So we meet fortnightly. Once that's happened, to methodically work through each guideline as scheduled. And as part of that, there are a million things we have to consider. So I'll give you some examples of some of the things as well that we're juggling. And it's putting together puzzle pieces that don't really fit neatly into one another. But we want to get as close as we can. So we look at other relevant guidelines in other areas of health in New Zealand and overseas and say, what are they doing that we can integrate into our CPG? We obviously, as I mentioned before, we discussed relevant new research. particularly if it's large randomised controlled trials that are really relevant to the pre-hospital setting. We look at other equivalent CPGs and other services. There's nothing wrong, in my opinion, with pitching a good guideline from another service. Why reinvent the wheel if the wheel's been invented somewhere else and we can steal it? We look a lot at Australia and the UK because their service makeup is the closest that we've got to here in New Zealand, but occasionally we'll sneak a peek at Canada and the US and maybe South Africa if we're feeling brave. Europe as well is always good to look at, but their model is quite different generally. They've got docs on their ambulances, they don't have paramedics, and so that has a whole lot of implications for us about it translating to the New Zealand context. Where relevant, we seek feedback from professional bodies on particular CPGs. So for example, if we're updating the pregnancy and birth sections, we'll go to RANZCOM, we'll go to the New Zealand College of Midwives, and we'll say, hey, what do you think about what we're doing at the moment? This is what we're thinking about changing. Do you have any feedback? Let's go through it. And generally, we get good feedback and we can implement it, and it's fantastic. Sometimes professional bodies contradict each other a little bit sometimes, so we have to work through that. Broadly speaking, we want to hear from these professional bodies because they're the experts in this particular topic. We also talk about common practice in EDs throughout the country. Sounds a bit basic, but the discussions do crop up. And then of course we think about and consider the feedback and suggestions from our people who are actually using the CPGs out there on the front line. Because if they don't like it and they don't use it and it's not fit for purpose, we may as well not write it and it may as well not exist. We need to talk about what's reasonable and pragmatic in the New Zealand context. That's really important. We need to understand what's viable from a cost perspective. And then ultimately, we need to make sure we've got consensus with the working group to establish whether or not the change can actually be implemented and we all agree with the direction we're heading in. So once the content's finalised, we send it to our learning media team in Aotearoa and St John, who make it look amazing, which you'll see in a moment. And then we release the draft CPG update to our staff, and we say, please don't use it on the road yet, but take some time to digest it, ask some questions, let us know if you spot the errors. And then we have it, it's usually about 8 weeks, and then it'll go live in our app for people to use. So I've talked about our app quite a bit. I'm horribly biased, but I do think it's a very good tool, and I'll just give you a bit of a demo or sneak peek. So once again, if you've got Android, you can download the app. If you are on Apple, you can download the app if you're connected to the New Zealand Apple Store. But anyone can access it on the website. So our CPG app, with something that's over 600 pages, there's a hell of a lot of guidelines in there, so navigation is really important. So we've got really good search bar and really good sort of intuitive interaction with finding what you need to find. We've got hyperlinks between sections, so if you say, now that you've intubated the person, move to the post-intubation section, and instead of going back, searching post-intubation, they can just tap the link, there's a circle down there, and it goes straight to it. Version history, simple things. If we update our guideline, we need to let people know that it's been updated, so it's highlighted if people can have a look at version history. And then of course you can download the PDFs of each of the sort of 3 documents as well. We encourage people not to print them, of course, because of the environment, but also because the moment they're printed off is the moment that they run the risk of it being out of date. Lots of personalisation with the app. It can be in night mode. You can favourite particular guidelines with that little star. You can create an account in your app and make notes against each procedure. And you can select your clinical practice level. And so that can, depending on which one you select, can hide certain things and just help with navigation and narrow people into what they need to do. Soon to go live in our app is the medicine calculator. In a previous version of our app, this was something that was used the most by our staff. So jump into the calculator, pick the patient weight, round it up to the nearest dose, and then you can select your drug, your indication, your route, and it spits out what you need to know, dosage, repeat dosage and times, the volume, the dilution. It takes you to the guideline. that's relevant based on the indication you've selected. It can take you to the medicine where there's more information about the particular medicine you've chosen. And if you've selected a clinical practice level, for example, paramedic, but you've also selected atropine, which is not in the paramedic scope, it will tell you with that red bar. So some safety stuff built in there as well. That's just an example of the medicine section. And then the other cool thing is, once you've selected the patient weight, it pulls through to the actual guideline. So if I am treating a 40 kilo paediatric person and then I go into my asthma guideline, it will give me the 40 kilo dosage for all the medicines that I need to administer to my patient, which is pretty cool, I think. We have the big guidelines for the comprehensive version of the guideline, and then you can toggle to a flow chart, which is dynamic. So, as you can see there, I've selected, or you might not be able to, it's pretty small, a 70 kilo adult, and you can change that at any time, but then you move through a dynamic sort of decision flow chart to guide you through exactly what to do for that particular thing. The other thing that is often a challenge in New Zealand is the transport destination for a particular patient at a particular time, depending on where you are. So we have developed, and this isn't live, this is like sneak peek stuff, but we've developed a tool where you can select the location you are in the country, you can select what filters you want, so for example, I am in Auckland and I want to see all the major trauma hospitals in Auckland, or I want to see what capabilities Auckland Hospital has. You can search all that within the app, that's pretty easy to do. Also within each hospital selected, so I picked Auckland Hospital there's phone numbers, there's opening hours, there's everything you would need to know to actually get to that place. And then there's a whole bunch of stuff. I mean, Auckland Hospital's got quite a lot of capability, but you can expand each one to understand, time frames, what actually is available, when they will receive patients. And if you need to phone, for example, an on-call cardiologist because you're coming in with a patient with STEMI, the phone number's all built in there, so it's all just in one place and easy peasy for our people. Similarly, we've got a number of low acuity pathways. It is almost impossible to remember all of this stuff, so this is why we've built such a cool tool. Once again, you select the location you're in and it drops down everything that particular for all the low acuity pathways in that area, and then each one gives you all the information you need to know. We've also got interactive checklists, so it might seem pretty basic, but checklists are a big part of what we do now, particularly in New Zealand and paramedicine, and having something interactive that you can click through encourages people to actually meaningfully work through the checklist. So, when I spoke to Quentin about what I was thinking of talking to you about, he said one thing that would be really good to talk through would be some of the challenges you come across when you are developing a clinical practice guideline or clinical practice guidelines in general. And I don't want to be a negative Nancy, but there are quite a few challenges. And I think one of the things that's really important about coming to places like this, where we've got a mix of representation of people from the health sector, doctors, nurses, not just paramedics, it enables us to provide some context about perhaps why we do things the way we do them in paramedicine. So firstly, workforce mix, that's a real challenge for us because we find ourselves having to write a clinical practice guideline for patients with STEMI that caters to the volunteer, ambulance officer, ENT in the middle of nowhere, right through to our high functioning critical care paramedics in busy metropolitan areas. That's a really difficult balance to strike sometimes, and it can be difficult when you're very metropolitan to put yourself in a rural person's shoes and understand their environment. So that's something we really have to work through when we're developing a guideline. And then equally, we're quite volunteer-centric because we rely on volunteers for production of our ambulance service, whereas Wellington Free and the air sector, who contribute also to the guidelines, is less of an issue and less of a focus for them. So it's just something we have to work through. Funding models, no one likes talking about money, but unfortunately it is, it's there, it's a problem, we need to work through it, and ultimately everything we do and everything we implement comes with a cost. So new medicines, new equipment, education, all comes with a price tag. And depending on the service you run, there's different funding models. We're 81% funded for operating costs. Other air providers have different funding models. And for us with our big service, relative to the other contributors to the working group, our ability to scale up and implement some of these things is much more challenging. And so, striking a balance and reaching consensus and not feeling like the other contributors to the working group are feeling cut off at the knees, that's often a conversation we have to have. Catering to different environments, so when you're writing a guideline, you have to think about, as I mentioned before, the urban, the rural, the remote, the road versus air component, what that means, different climates. We've got people landing in, alpine environments, semi-tropical, right through to metropolitan. What does that mean? And how do we make sure that irrespective of where you are in the country and where you're treating your patient, the practice guideline makes sense? Real estate, this is quite a big one. So whatever we do needs to fit into an ambulance, a helicopter, or one of our kit bags. And that creates some real limitations for us, I think. And those limitations are space, they're funding, and that limits our ability to have diagnostic tools, it limits our ability to have a wide range of medicine options, a wide range of equipment. And so sometimes, you're often making these sacrifices. And with us, particularly in our ambulances at the moment, if we want to introduce something, we have to take something out. Like we're pretty full. Geography, so it's not just about what you can do, and it's not just about what we want people to do, but it's about where you are and where you're taking your patient and where is most appropriate to take your patient. We've got destination policies for STEMI, spinal cord, major trauma, stroke, but we also need to think about if we have performed rapid sequence intubation in, pick somewhere, the middle of nowhere, and the nearest hospital is a small cottage hospital. It's not always going to be appropriate, arguably never appropriate, to then transport your patient to that hospital that's not set up to receive an intubation and ventilated patient. So how do we write a practice guideline which says, right, you've done X, now you need to work through this decision model to establish where you need to go, and then whether or not that can be by road or whether you need to request a helicopter, and how long that helicopter is going to be, and then what do you do if they can't arrive, and where do you meet them, and do you stage in the hospital, and we have to incorporate all this stuff so when someone's reading a guideline, they know exactly what to do, irrespective of where they are. New evidence and research, I've talked about this a bit, but one challenge that we face, particularly in paramedicine, is we're pretty new. And so because we're new, there's often a paucity of evidence in that particular context, in the out-of-hospital sort of emergency setting. And we've got the military-based stuff around trauma that's out-of-hospital, but the civilian pre-hospital paramedicine body of evidence is not particularly big. And so what we find ourselves having to do is, of course, we consider research that's conducted in an in-hospital setting, and we extrapolate it as best we can to paramedicine into the New Zealand context, but sometimes we just have to settle with close enough is good enough, to be honest. And then finally, this is kind of an interesting one, and I think it speaks to why I was excited to talk to you all about this today, is that often our staff will follow the procedures and they'll do everything right according to what is dictated as per their authority of practice. And then they hand over a patient in hospital and they get challenged by a doctor, a nurse, or whoever else on what they did, even though they followed their procedures, because Dr. A didn't agree with the fact that paramedics can administer ketamine. Dr. B or nurse Z didn't like the fact that critical care paramedics can intubate using RSI. So that's a challenge on a day-to-day basis that some of our AMBOs experience, and it's not helpful with relationships between professionals. But I do think really what it speaks to is that we have a number of challenges writing procedures, which I've just outlined, that often there isn't an appreciation of because you're not working in that world. And so I think, while it's a challenge, it's just an education thing. I don't think anyone is going out to be rude or offend anyone. It's just lack of awareness of sort of everything that we're juggling and how close we're trying to get those puzzle pieces together. So I'm going to finish on some positive stuff because that was quite negative. First things first, advantages of our clinical practice guidelines in New Zealand. Yeah, we've got challenges, but they're not insurmountable. We make it work. It's just about working through them in a way that's sort of robust and defendable. We think we've got a pretty robust development process for these guidelines. As I spoke before about the process we go through, hopefully you also feel the same, that it's really robust and pretty defendable. We think that having a base set of CPGs that are developed by the emergency ambulance sector in New Zealand, that every ambo in that emergency ambulance sector is using, whether you're in a helicopter or you're in a road-based ambulance, can only be good for continuity of care. Certainly it's safe for patient handover, because if I'm handing a patient over to someone in a totally different organisation, in a helicopter, in an ambulance, doesn't matter, and we're all singing from the same song sheet, and we've all been, following the same procedure, or we need to work on a patient together, that's really useful. Paramedic Council endorsed the CPGs, that's an advantage, we like that. Flexible, agile and fast, so electronic, we think we're pretty flexible. Sometimes it's pretty hard to move the dial in medicine quickly or on practice. This is something that we can do fairly quickly. The app, I don't know, tell me if you think I'm wrong, but I think it's a really good tool for our people, particularly when it comes to the ability to, on the road, make decisions about treatment, about drug doses, about transport destinations. There's a lot there. And we have had feedback from lots of people. This is not me tooting my own horn. This is not me tooting Aotearoa St John's horn, but we get feedback a lot that our CPGs are world leading. I would encourage you, if you want, is literally just Google search New Zealand ambulance CPGs and you will come across it. Have a peruse, see what you think, and you might be surprised at what you find. You might be surprised at what we do in paramedicine in New Zealand. So I'm here to answer any questions if you've got any, but that was my picture.
Do you have any questions for Hannah?
Referring to the CPG guidelines, how often do you see people making a decision after moving away from the guidelines? So,
Yeah, we're pretty enabling with our CPGs, and that's one of the things that we often get comments from internationals coming over to New Zealand and learning to use our CPGs. We provide a lot more flex and autonomy with our specialist paramedics to make decisions that are potentially outside of our CPGs. But we've got a really robust audit process, and we've got a really good culture actually in our organisation of people putting up their hands and going, I went outside the guideline, this is why I did it, I'm happy to receive feedback on it. Our docs are really good, they're really supportive. We don't tend to take a punitive approach, and that has paid dividends with people being open and honest. So it's pretty rare we get people going outside the guidelines and making a grave error, which is really good. But we've also got lots of mechanisms for people to gain permission to do things sort of out of scope before they get to the point where they're having to do it without talking to anyone. So, we've got access to specialist paramedics on our clinical desk and our comm centre, which they can call at any time, and then we've got a doc on call at any time, like 24/7. So unless you're in the middle of nowhere with no reception, which does happen in New Zealand, it's pretty rare.
Alright, let's hear it for Hannah. Thank you very much, Hannah, for coming along. We've been on for the last couple of years coming to Queenstown. I had no idea what the ambulance service could or couldn't do, so really appreciate you helping us out tonight and sharing some insights there. So that draws a close of the melodies of the week.
And also